You heard from our Cabinet Secretary, the progress so far is really promising, and it absolutely is. And I take my hats off to all of you who are spending your time really focused on the development of this service in your area for your communities. In this session, we're going to hear from representatives of the 6 health boards who are working to develop their own local fracture liaison provision. The presentations are going to be about 10 minutes, so I'm going to try and keep people to time. You'll know how difficult, if any of you ever chaired these sorts of sessions, it is to get people to stick to time and move on. But as I said, we've got a restricted time frame, so we're going to do our absolute best. But I know they've got such a lot to share. They've got amazing progress to share with us. They're going to describe some of the challenges that they've faced, but they're also going to describe the plans that they've got for the future. So I'm going to sit over there. I'm going to invite colleagues up one at a time. It's going to be a little bit rapid fire, but I'm absolutely sure we're going to get a breadth of information, knowledge and understanding about the services, and also the difference that we're already making across Wales by our individual and collective effort in relation to these services. So firstly, I'm going to welcome Dr. Swapna Alexander to the stage, consultant geriatrician, who is here to tell us about what they've been doing in Betsi Cadwalder University Health Board. Thank you very much.
Good morning, everyone. And thank you. I'm from Betsi Cadwalder, which is not the only trust in North Wales. It's quite a big trust, and it started off as 3 separate hospitals, which is why we have a slightly different service model in the 3 hospitals. Right, now, we are really going to talk about the operational challenges, and as I said, we have 1 established service in 2 hospitals, and we are in the process of establishing the service in the 3rd hospital, so we are kind of established and new service together, so we've got challenges on both sides, established and new. Right, now coming to the gap analysis which the ROS kindly provided with us, this is what we need, a band 6, a band 5 and a band 4 model from nurse and admin, as you can see here, and radiology and admin service, it is still yet to be decided. Now, I don't need to explain about the hip fracture, the savings related to hip fracture care if we establish an ROS, if we establish an FLS service, and you can see the cost savings in all Wales that we can save, 63.7 million, and in Betsi Cadwalder itself, 13.7 million. It is a huge trust. Now, coming to the average benefit per year, you've already seen these figures in the morning. It's almost 2.7 million pounds a year, which we can save if we have the FLS service established and running as we expect it to. And the number of patients expected a year in our trust is going to be about 5,600. This is the expected projection in 2024. Now, obviously, the FLS DB recommendations are to improve the identification of fragility fractures and to assess the patients within 16 weeks of their fractures. And we should work with our local providers to ensure access to DEXA. And obviously, we need involvement of senior stakeholders. I think this is an important aspect, and which is why we're all come here today. Now, coming to our SWOT analysis, now each trust obviously has its own challenges. The strengths of our service are we've already got a dedicated FLS service model to work from, as I explained, in 2 of our hospitals. We have senior clinical engagement, which is very good. We already have FLS governance in place. The real plus point of our service is everything is co-located in one setting, and I'm the lead of both these settings, like the DEXA service as well as the FLS, so it works very well, so we can cross-cover and we can interlink very easily, and patients go through one-step phase. They come in for the DEXA scan, they have their FLS assessment, they see the FLS nurse and they go away, so it's all one-stop shop. So it is very, that is a huge strength of our model. The weaknesses are, obviously now, since we are establishing a new service, we've got to factor in the fact that we have to provide more DEXA scans, and we have limited DEXA availability. I don't need to say anything about financial positions, and obviously links with the local fall service. Our trust is huge, and obviously the geographic area is huge, so that's a huge challenge for us. Admin personnel to enter data, which is the big problem. Even though we have an FLS service, we don't enter anything into the database because we don't have admin service. That's our weakness. Opportunities are obviously to increase the service. As I said, we already have an established one. We want to increase it to the 3 hospitals to obviously establish more patients to be managed by the service. and we want to establish the new FLS site. Now, obviously, we want to have a hub and a spoke model to involve the new service in the third hospital. And we are now, after a meeting a couple of weeks ago in the World Congress of Osteoporosis, I had a chat with Inder, and now we've realized new ways and systems of identifying patients. So we're going to be using RADIS to increase identification of our fractures. And I'm not saying really threats. The problems related to our service are obviously we need to outsource DEXA scans because our current service cannot provide the DEXA scans which would be needed for the new service to be developed. So we're looking at outsourcing into our local hospital in Oswestry, not across the border, sorry, it's not our local hospital. Staffing numbers are obviously a problem. We need to increase the staffing numbers in order to develop the whole aspects of the service. We deliver the identification and DEXA scanning service very well, but the follow-up we don't deliver so well. So we need to increase our staffing numbers in order to develop the extra parts of the service. And the threats are, as I said, even though we are a seamless service and everything is co-located, the problem is we provide DEXA services, specialist clinics, and the other big problem is treatments. I don't know how many of you have problems with that, but because we deliver the treatments also, a lot of our time is given up in doing these things. So the time spent purely on FLS services is quite less, because the minute you start a service, you have all the ramifications and you've got to deal with all the ramifications, and we've got to link in with all this. And obviously once a patient embarks on the journey, the question is, if they need treatments, we have to follow them through, and that is one of the threats in our service, because obviously we didn't think about all this when the service started. You've got to link in all these things when you start a service. So just to warn you people who are starting out. Right, the operational challenges, just to summarize, it's a large health board with three, our hospitals are called IHCs, I think this integrated health centers, sorry. Yes, sorry. And each IHC has a different population with different needs and differing priorities. And as I said, we have one functioning FLS serving two health boards, two IHCs, and the third one doesn't have an FLS, which is a slight inequity of services, and the inadequately funded DEXA capacity to cover the third IHC. But we're working on it, and I think it's so nice to see everybody here with the same vision in mind, and we obviously all want to work towards that. So the plan is, what does good look like? Obviously, the good is to have a standard FLS in all three sites. So continue with the two sites and engage with the third site. So obviously, the central and west are already existing. We want to link with the east site. And to maintain links, as I told you, with the hospital across the border in order to improve our DEXA provision so that the services can run without a problem. The other thing is false risk assessment in all patients. We fall down very significantly with this, so we want to try and see how we can develop links so that we can do false risk assessments on all our patients. And follow-up is one of our huge threats, as I explained. We don't have the personnel for that, so we need to look into that. This is another huge challenge, but this is what we are working for, and this is our short-term aims in addition to the longer-term goals. Thank you.
Swapna, thank you. And interesting to see the different approaches across the integrated health communities, and clearly specific challenges in Betsi in terms of the geography as well, and how you're trying to develop services equally across the patch. So thank you for that. Okay, we're going to move on if that's okay. So our next speaker is Professor Michael Stone, Consultant Physician and Director of Bone Research within the University Hospital of Landock. Professor Stone is here to represent Cardiff and Vale.
Yeah, I mean, you're going to keep seeing this slide. It's 500 hip fractures or so each year in Cardiff. And I was just discussing this with Anthony. I mean, it's an extraordinary number of beds, 58 beds every day of the year occupied by patients with hip fractures, which is absolutely astonishing, which of course comes at considerable economic and health costs. And we know from the ROS economic calculator that if we have a fully implemented FLS, we're going to save money. It's very obviously cost saving. So this is a classic example of value-based healthcare, if you fund it properly. You're all familiar with this, the 80-50-80 FLSDB recommendations. We get nowhere near this. So if you're really doing the gap analysis, we underperform basically quite badly on this. And that's because we're underfunded and we don't have the staff. So the SWOT analysis. I did do this. In fact, my colleague Jane Turton did it. And then I added some slightly controversial comments to her comments. For strengths, I mean, I think to a certain, this could be a weakness as well, because we've been going a long time, and then people think, oh, well, Cardiff, they've got a service, they're fine. You don't need any extra money. And I think politically, Cardiff are often at the bottom of the pile, and they think, oh, we don't want to send it to Cardiff, because they've got it all already. But we've been running an FLS service since 2010. We do use electronic case finding, so Cassim talked about that. It doesn't come without its challenges. We haven't got time to go into all the ins and outs, but we do that. It's digitized. It saves a huge amount of time. We get on very well with radiology. That's good. I've got a very experienced team, but that's a euphemism for some of us are getting old. And although I'm not dwelling on it, I have 281 days and 22 hours until I retire. And so my app is telling me live. We do have a good established bone clinic service, so we can look after these patients beyond a year. So we have a good comprehensive bone service. We're part of the ADOPT study, the AI vertebral fracture identification study that Cassim's leading from Oxford. So that's really good. We're in a good position to develop further our vertebral fracture services. Weaknesses. We're doing a bit better, and we work with orthogeriatricians. We do have orthogeriatricians in Cardiff. Oh yes, Anthony and Will are here. And the collaboration is a bit better, but it's still suboptimal. Again, we're understaffed to really comprehensively have an FLS for the inpatients as well as the outpatients. We lack admin support. We're running at full capacity with our current staff. And it's a recurring thing. Some of us are getting older, which could be a weakness. Oh, sorry, didn't mean to press that. Opportunities. Yeah, okay, if we have new staff, we can expand the service. We can use AI for vertebral fractures. We have a self-injection program for denosumab. There's a strong argument for moving away from default prescription of oral bisphosphonates. One of the treatments is denosumab. We have a self-injection program, which is cost-saving and highly effective. Admin, more admin support, we can use the FLSDB better. We might be able to offer training to other centres. We actually already do a bit of that. Threats, again, our senior workforce, you know, I'm retiring soon. Financial constraints. Then the last point is this. Although we've interacted really well with the innovation department, with the values-based healthcare team, both for our self-injection program and FLS, it's very clearly cost-saving. It prevents people coming to the front door. But still, at the last point, there could be a lack of buy-in to value-based healthcare, particularly within our health board, despite overwhelming evidence. And I think I talk about that again. Operational challenges, which are obvious from the SWOT analysis, lack of long-term funding for a full FLS. We've talked about retirements, admin. Yeah, this interdepartmental collaboration. And it can be difficult. If you're trying to work with orthopedics or know who does what, it's often very, very difficult. And this business of convincing commissioners to embrace value-based healthcare, which I think is epitomised by the FLS model, you can fall at the final hurdle. So we've had an offer of extra monies for 2 extra nurses, full-time admin, with this 1-year funding. And the executive board say, yeah, that's great. Our directorates say that's great. And then the medicine board in the middle say, hang on a minute, those savings don't help medicine. That's A&E, it's front door, it's orthopedics. So no, I'm not funding that. I'm not committing to funding beyond a year. So I think that's still a real issue. And you hit these hurdles, barriers, at the very last stage of the process when you think you're home dry. But I'm confident, having talked to Anthony, that I can overcome that particular hurdle. So what does good look like? Well, yeah, a fully funded, ongoing, long-term FLS. Thank you for listening.
Michael's done so well on time. Got time for a question if anybody wants to raise one?
Probably aren't any.
Yep, we got one in the front, thank you.
Mike, that problem that the benefits don't fall to people who provide the service, isn't that, I thought that would be less of a problem in Wales than it was in England. You're still finding it in Wales.
No, it's exactly the same problem. It's just the structure of the health board. So you have the executive board, and then you have all the different directorates. So you have medicine board, and then you have geriatric medicine off that. We sit within that. So it's very insular. They're kind of silos, and everybody will, understandably to an extent, really protect that budget, say, for medicine, and say, well, why should I provide the funds for the ongoing funding of FLS, where most of the benefits will be reaped by A&E and orthopedics. So there's kind of a bit of an argument to put this somewhere else. So you have a kind of combination fund, a whole health board fund where you can have a separate pot of money to deal with this sort of issue. So people are very protective. But I mean, I was clinical director of medicine for several years. I know what's going on. But just by the very structure of management, it can be a barrier to this sort of thing, where very obviously the NHS is going to benefit and save money, and can't everybody understands that. But when it gets to the crunch moment, you can still come up against the barrier. I'm not saying we won't get over that, but it's definitely an issue.
Yeah, I mean, there'll be lots of experience in the room about managing this, including in my previous role, so
Sure.
completely get it. But it is about how individuals see their function and role. Is it about taking that broader patient perspective, or is it about, I've got to manage my budget in my department? Yeah. And I think we have to rise above that, because the integrated health board model in Wales was there to give us that real opportunity. So I think there is something inherent in the way we work that sometimes distracts us from that mission, which is the one we were sent on.
No, absolutely.
But
absolutely.
Thank you for the question. Thanks as well. Thanks. Thank you, Michael. Okay, we're going to move on to Howell with thanks to Professor Stone and Dr. Will Backen, consultant physician.
Thank you. It's always nice to be in a room filled with people who are as obsessed about bone health as my wife tells me I am. It's always hard to follow Mike in anything, so I now have to follow Mike and stick to time, so that makes it even harder. I'm going to try and very briefly summarise where we are in Howell, again from Inda's gap analysis, which I agree was not really a gap analysis in the conventional way. So one of the things that we've done in Howell really as a kind of progress update is, as we know, osteoporosis is organisationally complicated. It falls between different specialties, it falls between different professions actually within an organisation. And I think actually one of the things that's really important is that we recognise that in Howell, and the organisation has. So they created a bone health lead post to try and cut through some of that complexity, which I think is really important, and I was fortunate enough to be appointed to that last year. And then kind of the good update really is, so we had a business case approved for a whole health board FLS incorporating the value-based healthcare approach at the end of last year. So really our update is kind of, we're working on it and it's coming. And I guess probably one of our big, real ongoing challenges, which almost kind of echoes kind of the two previous speakers, is around DEXA. So we have a fixed DEXA scanner up in Brongleis in the north of the health board, but we have the majority of our population in the south is served by a mobile unit from Swansea Bay, and we've got big waiting lists from referral to scan and then from scan to report, and that's obviously one of our ongoing challenges. Again, very similar slide to what's been presented previously. So we've got 4 acute sites in Howell. We've got 3 centres with acute orthopaedics. So it's about 800 hip fractures a year, which works out at somewhere in the region of probably 3,500 to maybe 3,800 patients a year expected for the FLS. This is our agreed model. So we're looking at 5 Band 7 FLS practitioners spread across the health board. The job adverts close next week, so not that I'm shamelessly plugging it, but please feel free to come and have a chat. And we've got admin support, which is for, as we've heard already from Professor Gervais and others, you know, that's absolutely fundamentally key. So we're going to have a full-time admin person on each of our acute sites. And we've also got small amounts of funding for non-staffing costs as well. In terms of service costs and healthcare benefits, again, I'm not going to stress it because we've seen it a few times, and I'm sure we'll see it a few more times going forward as well. Again, this slide is very familiar from the two previous presentations. I guess the key for me is point 3. It's all going to be around DEXA services, and particularly as our identification rate goes up because of as we embed the FLS, then obviously we really need to make progress on our challenges with DEXA locally. In terms of our SWOT analysis, I probably now have to put strengths as number 1, is that I'm not going to retire at some point within the next 12 months, so that's a good start. Well, not that I know of, anyway. So we're starting in a good place. So we've had a functioning FLS in bronchiolitis in one of our acute sites for a long time. So from that point of view, we're starting at a place where we've got a functioning service in one site, and we've got specialist osteoporosis services on our other sites. So from that point of view, we're starting from a reasonable position. Obviously, the fact that we've had funding agreed for a whole health board FLS is a big strength. And I'd also, you know, I'm going to shamelessly plug West Wales. So although I don't sound it, I had the misfortune to train and practice in England before I moved home. My mum's from just outside Llanelli, and I think there's a West Wales culture which is a very much roll up your sleeves and do mentality, and I think that's really important in this. Weaknesses, DEXA, again, common theme. And although we've got 4 specialist osteoporosis services, there's some variation between those, and how those interface with the FLS, which is a whole health board service, I think is going to be something that requires a bit of ongoing work. And then, you know, another weakness, I think it's a weakness and a strength, actually, in terms of we're introducing a service on all 4 sites simultaneously, because that's what our population need us to do, thus that's what we're going to do. Yes, it's difficult, however, that's where we are. But I think it's one of those things whereby, you know, it's hard, but that doesn't mean that we shouldn't be doing it. Opportunities, I think it's really exciting to be able to implement a service like this across the organisation. And I think it gives you huge opportunities to innovate and practice differently, including technologically innovate. We've heard about some of the things that might include earlier on. And I think, you know, that's a really exciting opportunity. And the other opportunity for me is we've had a wide variety of interests in our FLS practitioner posts. And the really exciting bit for me is it's people from a range of professional backgrounds. So, you know, I've spoken to nurses, I've spoken to PAs, I've spoken to pharmacists, I've spoken to physiotherapists. And actually, if we can get a team embedded which has a multi-professional background, then I think that's a hugely exciting thing. Threats, we're in a really good place, I think, politically with FLS in Wales, but the worry is that doesn't continue and the focus and the spotlight moves to somewhere else. Okay, and I think, you know, we're building momentum, and I think that's really important, but that's always going to be a risk. And I think organisationally, the same is true. Priorities and organisational priorities, particularly within the current financial climate, they focus on different things. So I think it's up to us to try and maintain that focus. So what are our operational challenges? Well, you know, we all work in systems that are uniquely stressed at the moment. Certainly our system in Howell is stressed, at primary care particularly, and you know, these systems only work if you interface them with primary care. As I said, our FLS is a whole site, a whole health board approach, and we're interlacing that with site-based specialist services, and obviously they have different resource and different demand, and that's something which needs working through to make sure that we consistently give a high standard of care to people regardless of where they live in Howell. DEXA sounding, again, is going to be an ongoing challenge going forward. And as I say, I think, you know, we have admin support as part of our business case, which is a huge strength. And believe me, we had to fight pretty hard to get it. But the point is, I think, you know, there's still a huge amount of work that we can do incorporating IT systems to make sure that we're using all of our resource in the most efficient way. What good looks like, this is kind of slightly aspirational, but, you know, effectively it's a bit like Ronseal quick drying wood stain. It's exactly what it says in the tin. You want a reactive service on all 4 sites delivering, you know, high quality care. You want to underpin it with improvement methodology, For me, I really want a supportive and well-integrated team, particularly when you're running it across 4 sites. I think it's really important, and you know, we need to do that in a variety of different ways. I want a population with decreasing fracture rates. So, you know, that would be the one way of summarising it. The other way would just be that. That's what good looks like. So that's where we want to be, very succinctly.
Okay, well, good, thanks. Thank you very much indeed. Thank you.